So this is the first session of 3. This one really is going to be outlining HRSA'S expectations for federally qualified health centers. The presenters are myself, Joan, and Brittany. My name is Kristen Bigelow-Talbert. I am the Community Health Quality Manager at Bi-State Primary Care Association. The Vermont Rural Health Alliance is a health center controlled network, an HCCN, which is also part of Bi-State Primary Care Association. Within VERA, we have 11 FQHCs with 64 sites across Vermont. And Joan, would you like to introduce yourself?
Sure, I just had to remember to unmute myself. Hi, this is Joan Tulk. I'm the Executive Director of Community Health Access Network, also known as CHAN. We're also a health center controlled network, and we work with 9 FQHCs with about 28 sites in New Hampshire and 1 FQHC with 6 sites in Texas.
Hi, everyone. My name is Brittany Delene. I'm the Director of Quality Improvement with the Minnesota Association of Community Health Centers, and Breakwater Health Network is one of the fabulous HCCNs in our state. There are 8 FQHCs across 31 sites in Minnesota, North Dakota, Wisconsin, and Illinois.
Thank you, Joan and Brittany. And so these 3 trainings that we're bringing you is really a collaborative effort across our 3 health center controlled networks. So I wanted to make sure everyone is aware of that. For today, our learning objectives are really to understand why root cause analysis is what I feel necessary and beneficial. And it's also to prepare the FQHCs for their HRSA site visits, especially with regards to the performance analysis component. Additionally, we want to help folks understand how to develop your problem statements and gather the baseline data, which is necessary to then go on to do root cause analysis itself, which will be the focus of our second session, and then how to take those root causes and develop action items, which is the focus of our third session. Okay, so oftentimes our lives are hectic and things are crazy and we're just going with the daily flow. We're just getting things done. And we don't have the time to stop and look and what could possibly be improved, what can be made better. And a big part of this is actually understanding what the root causes are that are driving these processes and outcomes that we're seeing. So what I often hear when I talk about root cause analysis is it really necessary? I already know what the problem is, and I know what I want to do about it. So here's the challenge. The symptoms you see are really just the result of things that are hidden, the stuff underneath that you can't necessarily see, that may not be obvious. And so these symptoms, these outcomes, this behavior is really the tip of the iceberg. And oftentimes we don't take the time to really dig and see what we're not seeing, what's not obvious. And resources can be wasted by jumping to a solution that isn't even really going to address the problem. You know, I think of it as the symptoms you can see, and addressing those symptoms alone is like putting an expensive Band-Aid on a wound that requires surgery. It may hold temporarily, but it won't actually fix the problem and the wound will fester. So without addressing that root cause, that underlying issue, you're just going to see these problems again and again and again. So I want to tell a little story about why root cause analysis is really important anyway. Many of you may have actually heard this story, and if not, welcome to it. It's the story of the Lincoln Memorial mystery. So the walls of the Lincoln Memorial were crumbling, and folks were kind of wondering what was going on and why these were crumbling when this is supposed to be really good stone and supposed to last for centuries. And so they thought they knew what the problem was. It had to be those planes that were going overhead and that exhaust that was so toxic and corrosive, and that was the problem. So they were going to fix the problem by changing the flight path of the airplanes overhead. Now, this was a very expensive solution. People were mapping out what they were going to do. And then someone at the National Park Service came in and suggested that perhaps before going through this change of flight plans, they do a root cause analysis and make sure that that's actually the problem. So, why was the Lincoln Memorial actually crumbling? We're going to go through a quick synopsis of the 5 whys in this process. It's one of the methods you can use for root cause analysis. And this is a simplified version, as I'm only focusing on those that actually led to the root cause in this situation. But it's a fabulous example of this. So the question really is, why was the Lincoln Memorial crumbling? And they brought in folks that are involved in this, all the individuals who worked on the memorial, all of the individuals who were involved in the care and maintenance. And they asked this question of everybody. They involved the whole team. And they found out that there were harsh cleaning chemicals and a lot of water that were used to clean it every day. And then so they asked themselves, well, why is that necessary? Why are all these harsh chemicals being used? Do we really need to be doing that? And the response was that they did need to use all these chemicals and water because they had to get off the bird droppings. Because there were a huge amount of bird droppings all over this memorial, which is not exactly a pleasant sight. So of course they had to clean them to get them off for the tourists. So why were there so many bird droppings and birds in the area? What was so special about this that they were flocking to the memorial? Well, as it turns out, there were a lot of spiders living in the memorial, providing lots of food for the starlings and sparrows. So it was like a feast every day for these birds. So of course they would go to where the food is. So then they pulled in some other folks to ask, well, why are there so many spiders here? So, as it turns out, there were lots of midges, which is a kind of type of tiny insect that would swarm at the memorial at dusk, coming up from the nearby river and providing lots of food for the spiders. So the spiders had a feast, the birds were having a feast. All of these guys were happy. But why were the midges going to the memorial in the first place? Why were they going there? And the answer actually was because of lights. The lights just around dusk, so right at sunset, were attracting all of these midges. It was like a beacon for them. They were loving the light and going there and had this chain reaction, this effect that it actually made it so that the memorial was a mess of midges and spiders and bird droppings. And so they had to clean it all the time. And it was a real mess. So then, knowing this and the actual root cause, they were able to propose a solution of turning off the lights in the 1 hour time frame after sunset. They did this for 6 weeks and found an 85% reduction in midge infestation. So not only did addressing this root cause avoid spending billions of dollars, they were actually saving money at the same time by doing this. And I love this example because it really shows that sometimes addressing the root cause is easier and less expensive than the solution that you were originally going to jump to. So it can really show the benefit of this. So next, we're going to talk a little bit about HRSA'S expectations and how this all plays into those.
Great, thanks so much for that overview, Kristen. So as you mentioned, I'm going to provide an overview of the HRSA performance analysis. So the next few slides are going to be FQHC specific. So for those of you who are not health centers, bear with us for just a little bit here. So as you've probably already heard, HRSA has added a new component to their operational site visit called the performance analysis. During this portion, your clinical site reviewer will be facilitating a root cause analysis based on your UDS uncontrolled diabetes measure. The details are outlined within the site visit protocol, so when Kristen sends out these slides, the image in the right-hand corner here is linked. Otherwise, of course, you can just Google it and it pops up right away. They will be reviewing the results submitted on your SAC and your UDS trends over time. And I'm telling you that because it's really important that you have a solid understanding of your data and are prepared to explain those changes, why you've improved, why you've gotten worse, those types of things. This part of the site visit is non-punitive, which is great, meaning that it won't result in a finding. However, they do want you to set goals and they will be tracking them over time. Your project officer will be checking in on you on the action steps that you identify, which we'll talk a little bit more about shortly. And I was told by a site surveyor recently that the focus probably will change in the future. So diabetes is kind of the flavor of the month right now. But in upcoming years, it could change to hypertension, it could change to colorectal, pediatric obesity, who knows. So keep that in mind that this is not probably going to go away anytime soon. Next slide. In terms of who should be there, so the site visit protocol outlines who they think should be there. So HRSA recommends your project director, CEO, your CMO or clinical director, your QI director and staff, providers and other key management, but I recommend a cross-sectional staff, including dental, behavioral health, front desk, pharmacy, health information management, anybody who might be involved in your diabetes quality improvement work. They're really going to do a deep dive during that meeting, and you're going to want everyone's perspective there. So if you can pull them out, it's definitely worth doing. Next slide. In terms of preparation, the recommendations seem to vary by site surveyor. So we've had some health centers that were told, don't prepare too much. We really want this to be an organic conversation. Others kind of expect that you've done some work ahead of time. My recommendation is that it's better to be safe than sorry. Do a root cause analysis ahead of time. Get together as a group and identify your restricting and contributing factors. Definitely identify some potential action steps you may want to suggest. You'll really want to be able to steer that conversation because especially when you get with a large group of people and everybody's brainstorming all at once and it's the first time you thought about it, you might not end up with an action step that is really going to be conducive to improving your rates. So keep that in mind. Definitely do a little preparation ahead of time. Next slide. These next few slides are screenshots from the site visit protocol, and what they do is outline exactly what your site surveyor needs to complete. So in terms of contributing factors, they're going to need 5 factors, and they are those that push the trend in the desired direction. They should be factors that have the greatest influence on the trend line for the measure. So start thinking about things that have contributed to your performance. So maybe you hired another provider, maybe you hired a diabetes educator, those types of things. Maybe you're doing point of care diabetes testing. Make a list, do some brainstorming, and have those ready for them. Next slide. Same thing with restricting factors. So restricting factors are those that create barriers to improved performance. When documenting these factors, also identify the related root cause. So that's why it's important to do some of this work ahead of time so that you have a sense of what the root causes are. So I think a lot of us can kind of spout off, what our problems are, from, kind of a foundational level, but doing the work to figure out what is actually causing all of those issues is really important. Next slide. And then action steps. So as I mentioned previously, they're going to want 3 action steps by either the end of the meeting or by the end of the site visit. It seems to vary by site surveyor. So the instructions here, when responding, ensure all activities or action steps address and align with factors identified in the root cause analysis and will support the health center to improve or maintain performance on the measure. So definitely do a little work ahead of time. We've sat in on some sites, some reviews, and it's kind of been all over the place where, this person's suggesting this and this person's suggesting this. And because it's not, a full day thing, it can be between 1 hour and 3 hours from what I've seen. It's not enough time to really think about what types of things it's not enough time to think about all the different factors involved. So definitely do this ahead of time so you can steer this conversation, like I said previously. Next slide. They're definitely going to want SMART goals. They're very specific. They want SMART goals. So specific, measurable, achievable, realistic, and timely. So keep that in mind as you're doing some prep work. So these are goals that you'll be working on over the next 12 months. And as I mentioned, your project officer will be checking in on your progress through these goals on a quarterly basis. Next slide. And here are some sample action steps that we've heard from health centers who have recently gone through site visits. So, for example, increase the number of diabetes patients by X% to receive group visit services. Identify X amount of patients with advanced periodontal disease and successfully refer them to medical for a diabetes screening visit. That was a really great example of integrating dental into the diabetes work. By X date, 10% of patients who have diabetes diagnosis will be seen by integrated behavioral health. So as you can see, these are all specific, measurable. They definitely fall under SMART goals. What they don't want is improve UDS diabetes measured by X%. They definitely want it to be more specific than that. They want to know specifically what you're going to do so that when they do some tracking, they can hear specifically about the work that you're doing. And with that, I will turn it back over to Kristen.
Great, thanks, Brittany. So I have a little bit of a what came first, the chicken or the egg conundrum for you. So sometimes you'll see that there's a problem after you see your data, the reports that come out of your EMR or from other sources, and that's how you know that there's an issue. But other times you'll see that there's an issue if anecdotally, knowing within your practice what you see objectively. So sometimes you don't have the data to back up what you're seeing, and other times it's the data that points to the problem first. And either of these are a fine place to start. I would just dig a little bit deeper into each of these so that you have something to start with, because you really need to start with your problem statement before you do your root cause analysis. And this is key because developing a problem statement really steers your root cause analysis and will be something you refer back to once you get to the solutions brainstorming phase, right? So once you're at the point where you have a whole list of root causes and you have solutions that you think will work, you'll need to ask yourself, will this solution actually address the problem that we're seeing that we outlined in our problem statement? So they need to tie back. So starting with a strong problem statement is really key. And with regards to HRSA'S expectations for this year with the site visit and the performance analysis, they're really looking at diabetic patients with an A1C over 9. But in general, that's too broad of a problem statement to start with. There are too many avenues you could go down, and your root cause analysis would take a very long time. So you want to narrow it down. Use the 5 restricting factors that Brittany was talking about and develop a problem statement for each of these and do a root cause analysis for each of those 5 restricting factors. Now, when writing your problem statement, it's really important to know what to include and also what to not include. So you want to identify the gap. And what I mean by that is really kind of a pain point. What services are not being done, or what outcomes are looking poor, or what's the problem you're seeing? And kind of frame that within a time frame or a trend, a pattern that you're seeing, or within the last 6 months you saw X, Y, or Z, so that you can put some parameters around that. Also note what the impact of this is, the impact of the problem if it's not addressed, so that it adds some importance and can add some urgency and really kind of highlight why this problem statement is key to address. And if you have the data available, please use it. It can really help to strengthen a problem statement and also give you some baseline place to start with. And if you don't have data available yet, you can start brainstorming on what possible data options you have available to you for that. Now, some stuff to avoid including in your problem statement are assumed causes of the problem, where you think you know it's because of X, Y, or Z, or opinions. You don't want to include opinions or conjecture. You really want to stick to the facts. You also want to avoid putting possible solutions to the problem in there. It's human nature to jump to solutions when we see a problem. It's just kind of the way our brains work. But try to write down that solution somewhere else and put it in a parking lot for now, because it doesn't really belong in the problem statement and will just inadvertently steer the pattern of the root cause analysis instead of being organic like it should be. And also try to avoid incorporating external issues that are really outside of the scope of the problem. Really keep it focused so that you're able to do a smooth root cause analysis. So I'm going to give some examples here because I always find that examples help when talking about these kinds of things. So I have 3 examples, the good, the bad, and the ugly. So we have the first one here. We're going to go through them line by line. 45% of our patients aren't coming to us for their flu shot because they prefer the timeliness of getting them at the pharmacy. So what's the problem with this statement? It really is the assumption here, because they prefer the timeliness of getting them at the pharmacy. It assumes the cause of the problem. So that's inserted into there. So if we really look at the data we have available to us for this problem, like what is it actually showing us and what are the facts around this? So we have a revised statement that we suggest. So you could say something akin to, we're missing information on whether or not 45% of our patients have had a flu shot this season. It doesn't assume the root cause of the problem. It doesn't assume that they're going to the pharmacy instead. It just simply states that, hey, we don't really know what these patients are doing. Maybe we can explore different ways in finding that out. So the next problem statement here is that 30% of our patients with an A1C over 9 have not come in for their 3-month diabetic check. For patients with out-of-control A1Cs, ongoing patient engagement is necessary to help patients manage their diabetes. So we have some data here. We have the time frame. We have some information about why it's important. So this is actually a pretty good problem statement here. So let's dive into the next one. The problem is that the triage nurses aren't answering the phone, so we have a backlog of phone messages. There is a lot of issues with this particular problem statement. Opinion is really being in here. Pointing blame as well, which you always want to avoid if you want to have a good dialogue with all of the team. Avoid pointing blame at individuals. And so taking this and revising it to the facts. What are the facts in this case? What is it actually telling us? And so a revised statement could read that we have a backlog of phone messages in our system, 30 from last week, 23 from the week before, and this is not only a liability risk, but a patient safety risk. So here, we are not pointing blame, we're not assuming the cause of the problem, that folks just aren't answering the phone. We have some data and time frames that we can point to use as kind of our baseline. And then we say the urgency, why it's an issue, why we need to look at it. So there are some examples of problem statements. Please feel free to craft your own. All right, so I would be remiss if I did not talk about data. So baseline data is very important, but knowing your data, being confident of your data is also very important so that others can be confident of it as well. So what are your available data resources? What do you have available to you? Often folks have reports from your EMR. but those reports from EMRs can be limited, so the capability of reporting out can be difficult at times. So what other sources are available? Are you able to look at patient satisfaction surveys? Do you have some other reports that you could point to, or some national benchmarks, or even community metrics that can tell you a problem? It doesn't have to be data that's internal to your organization. It could be that you look at, for example, the Youth Risk Behavior Survey and say, oh, a lot of kids in our area are experimenting with these, with opioids and with prescription drugs. Maybe we should look at that within our practice. So there are lots of things you can look at that's available to you. So think outside of the box here, but what your sources are that you have available to you. And then once you find some that hold meaning for you, find out what criteria is used. And this is really key because you want to be able to replicate that exact measure after you perform an intervention to see if it had an effect or not. So you want to make sure that that criteria will be something that you can duplicate later, and that the criteria actually will tell you the story that you want to learn about. Oftentimes I see PDSAs with a numerator and denominator and percentages for measures that are related to what they're trying to address, but don't actually tell them if the intervention that they're doing is having an impact. So make sure the data you're using actually tells you the story you want to learn about. That's really important. And then make sure the data is valid. Take it back. If it's, let's say, a rate of A1C testing to make sure that all your diabetics are having their A1Cs done regularly, take that data back to the providers. Show them their rates. Ask them, does this look right to you? Is this verified? Do chart reviews, just a few charts, just to make sure that what you're seeing is actually correct. Because if you can't trust the data, then it can either point you in the completely wrong direction of pointing to a problem that's not actually there, or lead to mistrust in quality improvement itself if you're not able to get buy-in from your providers and from your staff because they simply don't trust the data you have in front of you. Make sure your data is valid and trustworthy. This is really important. And also, be careful, be cautious. Don't just focus on the percentages of measures. Know what the numerator and denominator are. Because if you have, let's say, a whole bunch of provider dashboards for A1C testing rates, and you have some that are 80% and 90%, and then you have another provider that's at 50%, before you start jumping all over that provider and finding out, asking what's going on, look at the numerator and denominator. In this example, that provider had 2 patients, and one of them had A1C testing, and the other patient was in Florida. So knowing the data there and understanding the actual numbers behind the percentages is really important as well. Okay, so now you have your problem statement, or you'll be able to craft those together. You're going to be able to get your baseline data. Okay, what's next? What do we do now? Well, now you can do root cause analysis. Very exciting. This is actually going to be the main focus of our second session. We're really going to focus on the 5 whys in the fishbone diagram in this second session on November 2nd. So the 5 whys is basically the method that I showed you earlier with the memorial example, except there's a lot more to it than I showed today, and then the fishbone diagram method as well. So we're going to go into the meat of that in our second session. The third one on November 7th is going to be looking at the root causes that you've been able to identify, prioritizing those, figuring out which ones kind of rise to the top, and then how to take those and create actual action steps from them. So that's our third session as well. So now we're going to open it up to questions. There's also going to be a poll that's going to be popping up in a minute. And this is really your chance to ask myself, Brittany, and Joan any questions you might have. Please be sure to unmute your line so that you can ask those questions, or type in the chat box if that's easier for you. We'll keep an eye on that as well. Okay. Does anyone have any questions for us?
Has anyone on the call been using root cause analysis regularly as part of your quality improvement work? No one?
Okay, I see some things in the chat, so I'm going to look at those. Yes, the slides will be made available. We will figure out distribution within our 3 health-centered controlled networks and try to get it to everybody who contacted us in advance for registration to make sure that we will get these out to you. And we'll also determine how to distribute this session, the recording of it, to folks. We have a few folks who use root cause analysis and use it for all of their PDSA projects. That's fabulous. It's always a good place to start. And then, yep.
This is Kari. Can you hear me?
Yep. Hi, Kari.
Hi. At Northern Counties, we've been using this, and we just started to use it actually with our board of directors, which has been interesting too. Just so that they get a sense of what this looks like in from their perspective.
That's a great idea.
That's a great idea.
And what methods of root cause analysis have folks been using? Because there are several different methods out there, and we'll be addressing a couple of the common ones at the next session. The fishbone diagram, yep. That one is a great one to kind of figure out where things are. Flow charting, that's another really nice one, yes. I'm looking at the group chat here and folks are responding that way. Great, I'm excited to see how many individuals are really using root cause analysis already. That's fabulous. Has anyone found that the root causes that they discovered were not what they initially expected with something? We don't have any Lincoln Memorial examples here. So we have a question. Do we have any suggestions for encouraging staff to use data for the root cause analysis? So this can be challenging, especially when the problem statement is more of an objective nature. It kind of depends on the exact nature of the problem statement that you're using. Data is only as useful as it is trustworthy. So making sure the data is valid and trustworthy would really be the first step that I would do if we're getting a hard time with buy-in from providers or staff to look at the data, because that could tell you that they don't find it valuable or trustworthy. So that would be the first place that I would start personally, to just kind of see what we can do to make that data a bit more transparent and trustworthy. Joan or Brittany, do you have any advice in this area?
I think we struggled with that. It's almost like one of the stages of death and dying. You know, and the first thing when you give somebody some data, they if it doesn't look good, they assume it's wrong, and they go into denial mode. So we do spend a fair amount of time validating that the how like reports quality measures are in fact calculated and what's on the report, so that folks understand it. We've also found when we've done some of this quality improvement projects that when we start, we'll have like the baseline data. Let's say it's, you know, how well you're doing, you know, what percentage of your patients do have an A1C over 9 or no A1C, and use that to kind of get people engaged. But then we realize that that data, that type of report, doesn't get updated, doesn't reflect the improvement that you're doing quickly enough. So oftentimes you have to go to a much more low-tech way of tracking the data while you're doing an improvement. Once you've done the root cause analysis and figured out your aim, you know, what it is you're going to do, your first test of change is to come up with just even simple tally sheets or something, you know, other little process measures, so that you can see that, yes, you are making improvements until it starts to reflect in your monthly or quarterly reports.
I agree with Joan on that too. Sometimes your EMR is not even able to really capture the data you're trying to look at. So using a tally sheet or another means to capture that data can be really useful. And really capturing the data for a PDSA doesn't have to be complex. It can be quite simple, and in fact is often easier to implement when it is simple. I have a couple of comments here in the chat box I want to read. Tracy Tinker mentioned that yes, when we did the fishbone for the waiting room, we thought we had identified all of the issues, but uncovered many more when we did the fishbone with all staff. Staff started out questioning why we had to spend a lot of time with the fishbone and the process, but ended up seeing the value after we went through the process. And that Chan created a snapshot report which compares all SQHCs in New Hampshire, and using Chan, which is extremely useful for communicating the UDS measures to all staff. And remember, Chan is the health-centered controlled network in New Hampshire.
Thanks for that plug, Tracy.
Lynn asks a great question. If you discover in the process that your data is inaccurate based on documentation issues, can documentation improvement be an acceptable action from HRSA'S perspective? So in my experience, yes, it can be. Now this is, I want to caveat that all reviewers seem to be a little different on their opinions for this, but I have seen it as an acceptable means of an action step in a couple of FQHCs where they identified something similar to this. So I would have that as a possible action step, yes. And Rachel mentions that they've used flow charting and fishbone for diabetes for the current state learning collaborative on diabetes in Vermont, which is a collaborative we have that's statewide in Vermont here focusing on diabetes. So thank you, Rachel. And June has a great point. She said that we have found that the validation process can lead to multiple root causes. We have learned that the analysis should not end once the first problem is discovered. And that is a fabulous point, and again, something we're going to go into detail about at our next session. But yeah, generally, a problem doesn't have a single root cause. The example I gave you with the Lincoln Memorial was a simplified example to demonstrate the benefit of doing root cause analysis. But oftentimes you will see so many root causes, some that link to other areas, and it can be really kind of like more of a web than a straight linear discussion.
And that's what's nice about the fishbone diagram. But those of you are already familiar with it, and those others will be talking about it in detail at the next session, is the contributing factors. There could be like a number of things that are contributing to the less than positive results that you're experiencing. So, and then you go from there to brainstorm, okay, which ones of these are most important or easiest to work on first, and you go into multiple PDSA cycles from there.
Does anyone have any questions about gathering data or developing problem statements or any of the expectations that HRSA has for federally qualified health centers?
This is Kari again. I have a question. So when they're coming to do the root cause analysis, are they helping to facilitate that, or are they just sort of watching you as you facilitate it?
That's a great question. So what I've seen two different examples of this, and they really want to come in and facilitate the root cause analysis themselves. Now you'll get a lot of variance on whether or not they want to run through the whole process, assuming you've already completed this root cause analysis separately. Some reviewers still want to go through the entire process again, and others look at what you've submitted and say, that's great, and let's focus on the action steps now. So it's a huge variance and depends on the reviewer what they will actually do with the information given to them. But as Brittany mentioned earlier, one of the big reasons that we still suggest doing root cause analysis ahead of your site visit is because you get to those root causes earlier. You can then look at them, see which ones are feasible to actually take action on, and develop action steps. You can pull in the team to develop those action steps and PDSAs and solutions as a team. We have the time to do it, the resources to do it, instead of being put on the spot and saying, hey, in the next 15 minutes, can you tell me what 3 actions you're going to take to solve these monumentous problems? So it can really be to your benefit to know in advance what you're going to tell them for your action steps so that you can steer that conversation. So that's a great question. Thank you. Brittany, did you want to add anything to that?
Nope, that's exactly been my experience so far.
Great, thank you. Does anyone have any questions about the 5 contributing factors that they're supposed to fill out and what that's going to look like? Or the 5 restricting factors, which are always the ones that we're going to be doing the root cause analysis on, remember. So for each of those 5, they expect a root cause analysis. Okay. So in case folks want to reach us, here's our contact information. Vermont practices and New Hampshire as well, since Bi-State is a 2-state organization. You can always contact me, and New Hampshire practices, you have the additional option to contact Joan as well, and Texas, get to contact Joan. And Minnesota, North Dakota, Illinois, and Wisconsin can contact Brittany. So these are our email addresses, so feel free to reach out with questions, specific comments or feedback or anything. We're really here to help support all of you. So I appreciate your time today. Any last questions before we wrap up? All right, so I'm going to give you back 10 minutes of your life and have a fabulous rest of your day. And I look forward to seeing you all on November 2nd and November 7th. So thank you.
Thank you all.